All right, so there we go. So let's get started. So we're going to start close to where we left off yesterday with the pharmacotherapy. And I got a couple of good little muddy points, and some of them I'm definitely going to address towards the end when I take questions. But one of them is trouble distinguishing between schizophrenia and schizoaffective disorder. It's actually a pretty good point to talk about today when we're talking about bipolar disorder still too. So if you look at the diagnostic criteria under DSM-5, just so you guys know, under schizophrenia versus schizoaffective disorder, and I'm really sorry my voice is horrible today. I'm hoping I make it through class, so if you hear me sucking on a Ricola, I apologize ahead of time. I might end up having to do that, so I last for an hour of talking to you guys up here. But so just the big thing between schizophrenia and schizoaffective disorder is that there's a primary mood component present the majority of the illness, okay? So schizophrenia by itself, we don't normally think of it as having a mood disorder component to it. It's more of a straight up thought disorder. When you have schizoaffective disorder, there is schizoaffective either depressed type or bipolar type or mixed type, okay? There's 3 subtypes that we normally think about with the mood affect that's associated with it. So it's not exactly like taking schizophrenia and bipolar and jamming them together. A lot of people describe it like that. It's really having any of that mood affect that's present for the majority of the thought disorder process as well. Okay? Does everybody understand that? Does that make sense? Mm-hmm. So just basically take schizophrenia, throw a concomitant mood disorder that goes along in association with the thought disorder symptoms. So you have to have the underlying schizophrenia present to make a schizoaffective diagnosis. Okay. We also had one for slide 21. Suicide is 30 times greater when depressed. Is this when a patient has bipolar and is it experiencing the depressive phase? Yes, that is exactly what that means. So when you're looking at any patient that is in, especially bipolar 2, because that is more of a severe depression that can come from that, and your bipolar 2 patients, that is really dangerous, and if it's untreated, that is when it is really high. So if somebody has suicidal ideation and they're in the depressed phase, it's concerning. So how long does bipolar symptoms? I think it said must be present for them to be diagnosed, the onset. So usually we look at if it's affecting daily life, like rule of thumb, you can look at diagnostic criteria in DSM as well. That kind of spells it out. But it's usually present for about a month, okay, that symptoms are kind of going on. It could even be more acutely within, somebody had kind of like cycles into it quickly. It usually doesn't happen overnight. You'll see a little bit of a buildup. So you're going to expect to see things at least over a week, more of like a steady increase in one direction, but often it can be something that it's again not a one-time thing if it's depression to diagnose bipolar. So you have to look at the pattern as well. So the big thing in terms of like diagnostic time is that the history obviously is important. If it's just depression, you don't know if it's bipolar. You get the hypomania, then you instantaneously can make that diagnosis. If hypomania comes first, then obviously you can make the bipolar diagnosis. So some of that's a little intuitive, but clinically within a week, that is where diagnostically as a clinician, if you see somebody coming in, you'll usually hear, okay, it started out and then every day it got a little bit worse within a matter of a week. Okay. When you're looking for schizophrenia, some symptoms must be present for at least 6 weeks. That's kind of like where if you go to DSM again, there's some rigid things about that, but that's where you get into, is it a brief psychotic disorder versus bipolar? If somebody comes in, remember, schizophrenic versus bipolar, and they come in hallucinating, I may not be able to tell one from the next. Now, if they're manic and they're hyperverbal, it might give me an idea, but you have schizophrenic patients that could present the same when they're that disoriented. It's that response to medications that'll help guide you into that diagnosis as well. Okay? Is there other questions on that stuff? Are you good with that? And I totally am going to be having a review for you guys as well. I had looked at booking the room, and it was at a time that I had a conflict with the room, so they're looking for a new room for me to have you guys do the review on Friday. Okay? So we can totally go through that again in more detail if you guys would like during the review session. Okay. So pharmacotherapy. So we kind of touched on this a little yesterday. Again, here's your approved meds. Kind of keeping in mind your newer Latuda kind of came out and has looked at it's got the approval in depression. Yep.
When would the review be on Friday?
What's that?
When would the review be on Friday?
Well, it depends on when I can get the room. So it's probably going to be right after the therapeutics case study. Okay? So everybody's got the full benefit of going through case study and then coming in. If we had an extra day, I'd probably do it on Monday, but the exam's Monday. Would you guys find benefit in doing it earlier? If I could get something for tomorrow, would you want it to be earlier? Or does Friday work for most people? Friday? Let me just see a show of hands. Who would prefer Wednesday, tomorrow? Okay, who would prefer Friday? Okay, it looks like a little more for Friday, but you know what I'll do? You guys are in luck. My kids don't have school this week, so I have my father-in-law that I can stay a little later on Wednesdays. I'll see if some of you can't make it Friday. I'll see if I could stick around late on Wednesday. Most of the time, there's a room available at 5. When you guys get done at 5 o'clock? All right. Do you want to do it at 5 or 5:30? You guys like a break for a brain break in between?
We have an exam. So.
Do we have
You guys
lab
have an
afterwards
exam?
though?
Yeah.
But we have lab afterwards.
Oh, we have lab after?
Yeah, it's gonna suck.
Okay, I'll look at getting between like 5 and 5:30 when I can get a room.
Yeah.
Okay, and I'll do a little breakout session on Wednesday. If you've got burning questions, something's cloudy, I can do that, and then I'll do like a full review on Friday, for like key points for focus points as well. Okay. All right. Is that fair? That works. Yes. Okay. Good. All right, so let's jump into, again, therapy again. So we talked about benzos a little bit last time. Kind of remember, we're thinking of these as adjunctive therapy. They kind of treat the acute symptoms. We don't want to look at this as a mood stabilizer treating the chronic disease. It's kind of bringing somebody when they're acutely manic down. We don't want to use these in depression whenever possible. We know there's a high anxiety comorbidity, right? There is a high anxiety comorbidity. But remember, same thing you probably learned in anxiety disorders. Benzos treat the symptoms of anxiety, right? They don't treat the underlying disorder. That's why you use your SSRIs, SNRIs, or other antidepressants. So kind of the same concept here is you're using these short-term until your maintenance meds kick in for longer-term therapy. Okay, and we talked about Clonazepam and Lorazepam being your two probably primary agents you're going to see. We really prefer Clonazepam because of its longer acting effects, whereas Ativan is a little shorter acting. Anybody know why we don't like Xanax? Kind of cued you into it a little bit, where Clonazepam is long acting, Lorazepam is a little shorter. Xanax is the worst. So you guys, I'm guessing you probably talked about Xanax a little bit in anxiety disorders, right? And what's the big problem with Xanax? It's short acting, but what's the problem with that? You get those rebound withdrawal effects that kind of, you may not have anxiety, but on the withdrawal side you probably will, even if you don't have anxiety and you take Xanax and you have that quick drop off with the withdrawal, it has like this rebound anxiety effect that can happen. So especially in somebody who's manic, I don't want something that's going to drop off. I want something like Clonazepam I can give. It's going to stay in their system a little bit longer. Makes sense, right? It tapers itself up and on, tapers itself kind of off, longer acting, about 10 to 12 hours for its effect. So you'll usually see that given at least twice a day to 3 times a day. or at the very least to try and get sleep regulated. You'll commonly see it just given at bedtime if you're only going to give it once a day, okay, for Ativan or Clonazepam at bedtime. The Ativan, again, because of its shorter effects, you can see that instead of given 2 to 3 times a day like Clonazepam, you'll see that dosed at least usually 3 times a day. Could be every 4 hours even. Okay. And again, that's why you get up to some of those high doses you see there. Okay, so bipolar pearls. Again, when we're looking at these, kind of keep in mind you've got about a third of your population, 35%, they're going to be rapid cyclers and switch. You have about a quarter of them that are going to have an increased rate of cycling, including depression. And then your SSRIs are going to have that cause of switch in about just over a quarter of your population into mania. So again, really to keep this in mind, you don't know, especially when you're first coming up with a diagnosis, where they're going to fall in their cycling. That's why I'm bringing this up again and trying to remind you guys of that today. Initial diagnosis, you have to keep this in mind. You don't know if they're going to flip, if they're in the depressed side, and then they go to bipolar. If they do, they generally aren't going to be looked at as a unipolar patient. They're going to be bipolar, even though it can be medication-induced, right? Again, don't ever have your patients stop taking medications cold turkey. 250% increased relapse rate if they stop it right away. You always want to taper down over a couple weeks. All right. So the other thing, again, to keep in mind is depending on the issue with hypomania. Hypomania, they're still in touch with reality overall. There's really a good sense of feeling, but at the same time, there's some insight into what they're doing. So depending on the severity of this, depending on the impulsivity that a person has, depending on, if I've got somebody who becomes very hypersexual, I had a patient once, okay, that came in and was like, my wife likes when I'm hypomanic because I'm incredibly sexual. She doesn't get that all the time from me when I'm depressed. So, he's like, I don't necessarily feel like that's a bad thing. Well, it's a bad thing when, you're deciding to do it at work. That's too impulsive, okay? But literally, I had a patient, we had that conversation. And, the idea is that you look at the full picture. There might be times that if that's not an issue, and if the impulsivity doesn't seem to be a primary problem, if the person's not going off and having mass spending sprees, that you don't always necessarily have to treat the hypomania. You may not always, in every single patient, have to have a mood stabilizer if it's a bipolar disorder, that you're not having severe depression and you're only getting a little hypomanic for bipolar 2 patients, okay? It's patient specific. This isn't like a one-size-fits-all, the same as we've heard several times over with all of the disorders we've talked about. Acute manic episodes can be treated with a mood stabilizer. Usually, again, we're thinking our lithium, carbamazepine, and valproic acid with adjunctive benzodiazepines for anxiety, insomnia, as we just talked about. And then severe episodes with psychosis and agitation require antipsychotics, plus or minus benzos, along with a mood stabilizer. So the key here is, and I should probably have gone in and highlighted this, I want you guys to remember, if they have psychosis, you have to treat with an antipsychotic, okay? I have still, in psychiatrists that have been doing their job for decades, they come in and they're bipolar and they're in a manic state and they throw them on lithium. And they're like, they're not responding to therapy, they're still psychotic a week later. Well, duh. The lithium isn't going to treat that as fast. It's going to slowly bring them down. It will work. But it's usually going to be 1 to 2 weeks. Why do that to your patient? Give them an antipsychotic, get them out of the manic phase faster. Okay, so you want to remember when to recommend antipsychotics. Anytime they're psychotic, recommend an antipsychotic. Okay? All right. We also want to remember if no response within 2 to 4 weeks, this is when you can add something. This is, again, where our polypharmacy comes in. Really commonly we have to do that. If the patient is still non-responsive, then we look at switching. So the idea is, I wouldn't say, if you've gone 2 to 4 weeks into therapy, and you've titrated up to a decent dose, and they've been on that dose for about a week, and you don't see any benefit, sure, go ahead and switch. But a lot of the time you might see a little improvement, okay? If you see a little and you think the medication may be having an effect, go ahead and throw that second agent on there. It doesn't necessarily mean they're going to be on 2 agents forever, but at least until things get stabilized and normal and you get them regulated on 1, that's acceptable. Okay? So again, polypharmacy, not a problem to get them back down even keel. Mood stabilizer should be switched to another agent, or ECT can be used. Now, I told you earlier ECT can actually induce mania, right? Key here again is if they're not responsive. The idea of ECT is that though you're going in, you're causing a seizure, okay? You're causing the brain to have a seizure. You're increasing all of these neurochemicals. You're kind of upregulating the brain, but the idea is that it overall has a stabilizing effect to a certain extent to kind of bring things up to a certain level where things are normalizing. Not going to do that in all your patients. That's generally how we look at it as first-line therapy. But it is recommended if they are non-responsive after we've tried medication options. Okay? And if you look at the guidelines, they actually do say or. This isn't saying if a patient is still not responsive to the first mood stabilizer, a second mood stabilizer will often be added, or ECT. So that actually looks like it could be second-line therapy, right? If you look at the guidelines, that is what it says. It has an or there. No, in practice, we don't jump at that right away. It's when they are non-responsive, and then you add another agent, and then, so you really can look at that as, you really can look at that as like more of a third-line option, okay? Sorry. I hate that noise. Okay, after readmission, adjunctive agents are tapered and discontinued over 2 to 6 months. Again, no rapid discontinuation, even with your augmented therapy. Now, that can be in certain situations, especially your patients who have a history of substance abuse, again, which is about half your population, right? Whether it's alcohol, okay, they've never had a problem with benzos, let's just say, and they're addicted to alcohol. Well, guess what? One substance use disorder becomes real easy to feed into a second substance use disorder, so it puts them at a higher risk. So if you have somebody who we treat with an adjunctive agent with, say, Clonazepam, the idea is that you slowly can taper them down still, within 2 to 4 weeks, okay? Some might do it slow over 2 to 6 months if they're not having any side effects, and that's outpatient, slow taper down each time. So when I mentioned that rapid discontinuation happens 250%, and I said you have to taper over 2 to 4 weeks, I was including any agent, but specifically where you see here, don't confuse that, where it says and discontinued over 2 to 6 months. There is going to be situations that you can do it sooner, 2 to 4 weeks. After a response, patients with only 1 manic episode, they should continue on a mood stabilizer for at least a year, okay? Now, so that does tell you if they're manic, you want to try and just make sure you've got them at a point where they're not going to cycle into depression or cycle into another manic episode, right? So, when you're looking at this, it's important to remember if it's 1 manic episode, that doesn't mean lifelong therapy. If they have 1 manic episode and they don't have another one, yeah, definitely take that medication away after a year. Maybe there was a triggering event, something else going on. If they have 2, different story. You're looking at it a little bit longer, okay? You're looking at potentially, the severity plays a key as well. What was going on, the severity of the mania or the severity of depression, that'll key you into potentially lifelong therapy, okay? Bipolar 1. Lifelong mood stabilizer therapy is recommended for patients with 2 manic episodes, as I just said. Severe manic episodes, strong family bipolar history, more than 1 manic episode per year, or rapid onset of manic episodes. Okay? Yep.
Sorry, so what does that mean technically for the diagnosis? If they only have 1 manic episode and then treatment is discontinued after a year, does that mean that they're, how does that...
Still considered bipolar. Okay. You only need to have 1 manic episode, period, to put you in a bipolar diagnosis. And the problem is that if you were in that state where you ended up psychotic, the chance of something else triggering that down the road is higher. So even if you tend to cycle, say you just had 1 manic episode and you never had another one, you have to be especially careful if, say, you get an infection and I want to put you on corticosteroids. That's when you'll see that come into play again, and it'll be a triggering event to put them into another manic episode, which is why you got to be so careful. Okay? Okay. Bipolar 2, long-term prophylaxis for patients is recommended after 3 hypomanic episodes, or if a patient is required an antidepressant but becomes hypomanic. So the key here is, if you give them an antidepressant and they switch, you're thinking of prophylactic therapy to get on board there with the mood stabilizer, okay? And then again, if they have a history of 3 episodes of hypomania, you're probably looking at more of a repetitive cyclical disorder, and you want to stabilize that as a whole. And then again, it also again depends always on the severity of the hypomania, right? Breakthrough episodes, again, this is where you just have your benzos and antipsychotics when you need it for mania, and then antidepressants for depression. So you heard me mention the studies have clearly shown antidepressants compared to placebo in studies do not always show a favorable benefit. But the fact is that in some patients that they will show responsiveness, and if they're that severe, they're that suicidal, you really want to look at giving them their best effort to dysregulate their mood if it's that low. You want to dysregulate their mood out of the depression back to euthymia. So doctors, if there's, say, a suicide attempt or it's severe, you're really thinking augmentation can be appropriate. I mentioned the STEP BD trial a couple times. So again, this is kind of, I don't go through, there's some instructors in therapeutics that will specifically go really, really heavy into large hallmark studies and kind of have you know all the nuances about it. If I were to do that for anything bipolar, it would be this STEP BD trial. Okay? This basically was done by the National Institute of Mental Health, the NIMH, and offers all kinds of fundings that they've done since this is the largest study that's ever been out there, done in thousands of patients across the country. It was started by Gary Sachs at Harvard, a guy at Brown, and the University of Pittsburgh are like the 3 guys that have pulled all these other clinics across the country in. And they've done a lot of research on this large cohort. This was a really cool study because it was all bipolar patients. They didn't just have, like a lot of your drug trials do, where they have select patients, you have to have certain criteria. They just said, if you have a bipolar diagnosis, we want you on board. So there's a lot of co-occurring substance abuse, and that it's allowed, because of the population and tracking all this, a lot of breakouts to really tell us more about our bipolar patients. They came up with this standard care pathway, which is pretty much the guidelines I've gone through with you guys. I don't hand you the whole guideline and say 1, 2, 3, 4. The consensus is what I just went over, and that is exactly what the standard care pathway suggests. So your mood stabilizers, your anticonvulsants, and antipsychotics. The role of antidepressants, kind of what I told you. The literature doesn't have huge support for it, but you always want to look at when it's appropriate. When somebody has a manic or hypomanic episode that's severe, or 3 of them, you're looking at mood stabilizers, okay? All right, so now we get into the fun side of our mood stabilizers, and we could do an entire course, I feel like, if we really wanted to, on going into all the intricacies of lithium and Depakote and carbamazepine just alone, okay? There's a lot. I put these dual mechanisms of anticonvulsant actions here because you'll notice here, you've got your carbamazepine. We'll talk about lamotrigine today. We'll talk about valproic acid. We'll talk about Topamax a little bit, even though we shouldn't be using it for bipolar. It is off-label use inappropriately. And then zonisamide is, again, sometimes off-label use for mood. Topiramate and zonisamide, I just want to say, you'll hear me say it again towards the end of lecture, not appropriate to use in bipolar. Studies have never shown it superior to be truly effective. Topamax is probably the big one that a lot of doctors like to use because it's got some potential for weight loss indications, but it really is inappropriate therapy, okay? Time and time again, we've had studies come out. They used to actually use gabapentin. Neurontin is another drug they used to use all the time for mood. Completely ineffective. Should not be recommended for mood, okay? So you'll see that there's our anti-excitatory, anti-glutamatergic pathways that all of those drugs work on right here, okay? Oxcarbazepine, trileptal, and carbamazepine, Tegretol or Equetro is the brand name that's approved for bipolar. And then you've got your inhibitory, your GABA, benzo receptors here, where valproic acid also works on that. The idea where you're kind of just calming everything down with anything GABAergic, where your benzos down here play that role, right? The problem again with benzos is your tolerance, withdrawal, and all the other side effects with the comorbid substance abuse in many of our patients too, right? And then our antipsychotics, so they have the idea that they've got some of their sedative benefits, they've got some of their mood benefits there. When we're going through these, I'm not expecting you guys to like regurgitate a mechanism of action. I want you guys to know these clinically on when and where they're appropriate. I want you to know the side effects, the monitoring parameters, when to expect them. There are some of them that are very narrow therapeutic index, so you need to know those plasma levels as a pharmacist. Those should be like on the tip of your tongue when you go out on rotations. You should have a comfortable. I don't ask you guys to memorize a ton of labs, but again, there's a couple drugs here that you're going to need you to know. And you're going to see them again in seizure disorders. You're going to see them again in PK. So we'll have some reinforcement there, okay? All right, so in treating a patient with bipolar disease who is experiencing mania, which of the following mood stabilizers appears to have the lowest risk of switching a patient into depression? So if I were to think about switching somebody who is manic to depression, lithium, lamotrigine, valproic acid, or quetiapine, which has the lowest risk of switching a patient into depression? What do you guys think? Who thinks lithium? Lithium, couple? Okay. Lamotrigine. Okay. Valproic acid. That's good. Because that one we only use in mania, right? So lowest risk of switching a patient into depression. Probably not that one. And then quetiapine. Okay. So we got a couple hands up for lithium, lamotrigine, and quetiapine. From looking at that article, and we look at what is generally recommended for bipolar 2, I always say it's kind of nice to remember bipolar 2 is your Roman numerals as 2 L's, lithium and lamotrigine. We like to use in bipolar 2, and is sometimes used for depression, but here's the key. Quetiapine is actually approved for atypical depression. You guys talk about that with Dr. Teeter? Your augmentation agents like aripiprazole, Abilify, quetiapine, recommended for atypical depression. Yes? No? Ring a bell? No? So yeah, so the key is, and we're going to go over these, don't worry, but the key is that quetiapine is actually approved to treat depression, right? Atypical depression. So that's your answer. It does have the lowest risk. So lithium and lamotrigine, though they do treat it, the fact is that they're a mood stabilizer, right? If somebody's still going to go to depression, they still have some more of those, they have a little bit heavier central nervous system effects. So if you think about how quetiapine is working, even though it's a sedative, and you look at the pathways that we just went through, when we're looking at these, you don't see Seroquel listed there as much, right? With kind of looking at the GABAergic system, it does have some downstream anti-glutamatergic properties, but not directly linked as much as our anti-epileptics, anticonvulsant drugs do. Okay? So that's why quetiapine is the answer. Now, lamotrigine is what I have highlighted for you guys. If you look at your reading, they suggest lamotrigine. Okay? So this is one of those areas that when you guys are going through and you're looking at your literature, doctors will specifically go and say quetiapine every single time. The fact is that lithium and lamotrigine are approved for bipolar 2. This was lamotrigine's claim to fame and why it's been used rampantly for bipolar 2 now. Okay? So did you guys get lamotrigine from the reading? Those of you who put your hands up?
Mm-hmm.
Okay. So it's not a trick question. Quetiapine has actually got approval and could be an answer for you. But lamotrigine, in terms of the reading and what is the rationale for why it's one of the most prescribed drugs now, is not actually just epilepsy. It is bipolar. Okay? So I threw this up there because depending on what source of literature you look at, there's some confusion. Yep.
So Seroquel, is that the better answer?
So Seroquel typically isn't going to have a higher switch risk. If you look at your antipsychotics, it's lower. But if you look at your literature, when they looked at comparisons of mood stabilizers, they did find the lamotrigine, and the paper referenced that for your pre-reading, that lamotrigine is a little bit lower. So I wouldn't say I wouldn't say quetiapine in terms of clinically. I'm too concerned about it causing depression because again, it treats depression, right? So don't get that confused. It's just lamotrigine has actually had, when they've done some of those comparator studies, that's what it demonstrated. Okay. All right. So again, lithium and lamictal are your two you're thinking of for bipolar 2. All right? Bipolar 2, remember it is 2L. Okay, what is considered the mainstay of therapy in treating bipolar 2 patients with blank is adjunctive therapy? No, both answers are drugs and not classes. There may be more than one correct answer. We're going to go back to this as we go through. So think about what is considered the mainstay of bipolar 2 therapies in your patients, okay? And what do we look at as adjunctive therapy? So we kind of touched on it a little bit before, but we'll go back to this towards the end. And you guys should be able to answer that easy. All right. Lithium is really what we look at as our gold standard of therapy for bipolar 1 or bipolar 2. Okay? It can treat both. Depending on where someone's at in their cycle history, it doesn't work as well for, say, your rapid cyclers. See here, less effective in rapid cycling and mixed bipolars. But if they're not considered a rapid cycler at that point, most people will often look at lithium as a preferred agent in bipolar. Kind of your tried and true gold standard that you're comparing all other medications to. All right? So we know that it is pretty effective overall, 70% effective for an acute manic episode. Again, if somebody's psychotic, it still has about a week to 2 to really show its best effect to get somebody out of a full-blown manic state where they're psychotic. You should still augment. But even by itself, it is about 70% effective. Okay? So you're thinking of this, again, more as your maintenance drug. 20 to 50% relapse rate after 2 years. That's pretty decent overall for a cyclical disorder. Okay? So you are going to have people who are relapsing, but if you look at comparison to placebo or a lot of the other drugs that are out there, that's pretty good. Half-life is pretty long, but you notice we dosed it a couple times a day. Why is that? What do you guys think? We're going to go through all kinds of PK with this drug, but PK based. Why do we think that lithium is dosed a couple times a day with such a long half-life where you may not need to give it more than once a day? And we have controlled releases.
Or bioavailability?
It actually has decent bioavailability, but that's a good guess. It's really the GI side effects. They're horrible. If you have too high of a dose, it causes nausea and vomiting, okay? Especially nausea, high nausea risk, okay? So that's usually why we spread it out. So there are some patients you may actually see just take a nice heavy dose at bedtime. And if they can tolerate that, great, but you usually are going to see the dose at least twice a day. And it is dependent on renal function. Lithium is the only dialyzable drug. It is incredibly nephrotoxic. Okay? So if you remember nothing about lithium, remember it's going to kill your kidneys if your levels are too high. All right? So the half-life, if you have somebody with renal impairment, you're going to see that the half-life is going to increase for sure. It's going to kill your kidneys, and then it's going to stick around longer because it can't get excreted. So you want to watch out also with pregnancy and breastfeeding. There is this disorder called Epstein's anomaly, where the chambers in the heart, when the baby is born, there's not the separation there should be with the 4 chambers, basically. And it's pretty uncommon if you look at the greater literature. There's been some that say it's 1 in 1,000. There's been some studies that have come out that says it's 1 in 10,000 or more. But the fact is 1 in between 1,000 and 10,000 babies on lithium will probably come out with Epstein's anomaly, which it can happen in patients that are not on lithium as well, but not nearly as common as what you'll see in lithium. okay? And we know toxicity can be fatal. You really, really, really need to know your levels with this drug, okay? So we've got a lot of different formulations. I don't expect you to memorize, the tablet strength, okay? I want you guys, if you remember, instead of dosages, again, remember your plasma levels when we go through them. Again, the efficacy is there. So we've got specific research that they've done with the controlled release formulation versus the immediate release formulation. I generally like the controlled release because you do get a little less side effects. You don't have as high of a peak effect with the drug. And then, so if you look at efficacy and the mechanism of action, overall, when they've looked at escalith, you've got 60 to 80% effective for acute manic episodes within that one episode by itself. Again, it ranges at about 70%. I already said that, right? So right in the middle there. 80-90% effective for prophylactic therapy. So that's pretty high in a medication for a cyclical disorder that it overall will help prevent a second episode. And it does affect all neurotransmitters from production to release of the calcium channels when it goes in, and it has the effects and acts as a central nervous system effect. And it has some calcium blocking activity. We kind of touched upon that a little bit before. So when you have, hypercalcemia, you tend to see more depression. When you have hypocalcemia, you can have a little bit more of the manic side. So we know calcium has got some relation into mood. And this specifically works by blocking those calcium channels and kind of hopefully steadying things down to more of a constant rate, as opposed to having as much fluctuation that can happen too. When we look at this drug, again, it is an ion, it is a salt, okay? So it's really, really important to remember that. The basic is, this is an ion, this is a salt. What that means is, knowing that it's very toxic, if you get dehydrated on this drug, you can become toxic with the levels. When I lived in Florida, this was a huge counseling point that doctors always forgot to tell their patients. It's ridiculous to forget to tell somebody, if you get outside and you're mowing your lawn, remember to bring a bottle of water with you, because otherwise you could end up in the hospital with kidney failure. Okay? Don't underestimate the fact that it is a salt ion, and if you sweat, it gets retained in your body, your levels spike. The same as like when you get dehydrated and your sodium increases, right? Okay, and it has a competitive, it's competitive for salt. If you look at the excretion of the drug, okay, as well. So it's not surprising when we look at some of the side effects too, metallic taste and all those things, especially depending on levels, sometimes that can be an issue. So dosage. Overall dosage, usually we're going to start out at 300 milligrams twice a day, go up to 900 milligrams 3 times a day. I don't really care what the dose is. I'm going to be paying attention to the levels. Okay? I mean, you obviously have to have an idea of like starting and range, sure, but I might have somebody who has a level of 1 when they're on, 600 milligrams a day. I might have somebody that has a level of 1 when they're in a much higher dosage at 900 milligrams 3 times a day. The key is, don't forget there's different drug levels here as well. Acute phase. Somebody comes in acute mania. You have a higher blood level than your regular maintenance dosage. You don't want to stay at 0.8 to 1.2 forever. It's just acutely. The reason is that we know the closer to 1 you are, the more efficacy you will see. So you see the maintenance phase stops at 1. Over 1 is really when you see more side effects. So you acutely may actually be having side effects. Back in the day, before we had blood levels dosing lithium, they used to dose it by one of the side effects. So anybody know what the primary side effect most people think of when they think of lithium outside of renal issues? Anybody? From your reading? Nothing? The Pearls maybe? Tremor. Okay? So if you had a fine hand tremor, kind of like this, real fine hand tremor, they'd say that was therapeutic. When it got coarse and ugly, that was toxic. That's how they used to dose lithium. Okay? So even at the maintenance phase, especially in your adolescence, I would say they're a little more prone to the tremor effect. Even at the maintenance phase, the lower side of 0.4, we've seen patients at 0.2 or 0.3 that were intolerant of the side effects because the tremor was there and they couldn't stand it. So maintenance and acute phase, you still can have adverse drug reactions that we normally think of that happen around 1. So keep that in mind when you're looking at your patients. Just because they're at 0.4 doesn't mean they're not having side effects. Okay? You can go up to 1.4, but remember what I told you. Above 1 equals more side effects. It's kind of like that limit where we almost expect them. So you might even prophylax somebody with Zofran if their nausea is really bad with that. Okay? All right. As we talked about, this drug's got a lot of side effects. We're going to go into all of them in detail, but you want to look at where you start at it as a baseline with this drug. So baseline, you always are going to look at your kidney function. If you're severely kidney impaired, you need to take that dosage into consideration big time or not use it. Try another agent. Okay? I had a patient I will never forget. Was my first patient who actually died was because of lithium. I had a doctor that she was stabilized on it for years. She was actually at a like an assisted living facility, and she had schizoaffective disorder, and she ended up having lithium. She came into the hospital with a lithium level, I think, of like 3.7. Kind of shot her kidneys out, and tried her on a couple other antipsychotics and anticonvulsants that are recommended, and just nothing seemed to work like lithium. So he put her back against recommendations, put her back on lithium at a low dose, low dose, okay? And she ended up having complications from that and ending up back in the hospital. That was so it's one of those things that I can't stress enough, like, because yes, this one has touched me personally, but don't underestimate if somebody has creatinine issues. You have to be extra cautious with those patients, okay? When we look at the CBC, lithium does some interesting things. It actually increases your white blood cells. Not to the level you would see with infection. Normally, if I'm looking at a white blood count and, it's around 11, 12, 13 with lithium, it'll kind of bump them up. So in patients who actually have like a granulocytosis, there's actually times that when everything else is failing, they may actually put lithium on board to actually bump up the white blood cells a little bit, okay? So just kind of keep in mind that that is not something we think is serious. We're okay with that. It's not as high as it would be an infection. Say somebody's WBCs are 17, 18. Well, yeah, that's clearly an infection. It's just a little bit of a blip. That's expected. So it's good to get a baseline and see where those are at. Serum electrolytes and glucose. Obviously, you want to look at if the patient is coming in and they're dehydrated. That's going to be why you want to kind of look at their serum electrolytes. Okay. Glucose. Lithium has been known to cause weight gain as well, so you want to just get an idea of basic glucose panel, make sure they're not diabetic, which obviously if you're diabetic and you get the polyuria, polydipsia, can affect your lithium levels, and again, causes weight. EKG, pulse, and blood pressure. Have to do your vitals in these patients regularly. Make sure lithium has actually got cardiovascular complications associated with it as well. It can cause arrhythmias. Usually at the therapeutic dosages, you do not have to worry about it, but you want to rule those out before you start the medication, okay? And at high doses, it has been known to cause cardiovascular complications too. So we're saying above therapeutic range for that. And we'll go through that a little bit more in a minute. And a full history and physical, okay? All right, so when we're looking at the PK, your ADME for this drug, it's important. I don't go through this with every drug, remember. Okay, so these you do need to know. This is readily absorbed from the GI tract, so no problem getting this drug into the body, no bioavailability issues overall. Okay, the peak serum levels, peak side effect issues are going to be within 2 to 4 hours when the drug peaks. Okay, so again, a lot of this is your GI side effects. Readily absorbed in the GI tract, causes nausea. Remember to take it with food and to space out your doses if you have any of those GI side effects. Okay? Complete absorption within 8 hours. It has slow releases, are going to have the slower and more variable rate, but that's not a horrible thing because you have lower peaks of the drug. Overall body distribution gets into the system pretty easily. It's not protein bound. If you are looking at toxicity, this is the only time I really think about the cerebral spinal fluid concentrations, okay, is in episodes of toxicity. It's about half that of what you see as a blood level, okay? So brain concentration, again, half that of what you see in the plasma. So that's why when we start talking about the central nervous system effects that it can have and the damage it can cause if it's too high, that look at the plasma level, the brain concentration is half that. When we look at elimination, again, think kidney, right? 95% renally excreted. 80% of that is in the proximal tubule. 20% is excreted in the urine. So if you have kidney impairment, lo and behold, it's not going to come out of you as easily, right? Half-life ranges, again, depend on renal function, which also, of course, always look at your age, look at your calculated GFR, glomerular filtration rate, and then other disease states, concomitant drug use. There's a lot of drugs that interact with lithium. If it has effects on the kidney excretion, it's going to affect your lithium levels. So high risk for drug interactions. Make sure you pay attention to those when it looks at your dosing and why we need to check levels. It's exactly the answer to those two questions, okay? So what's that mean for dosing? Space it out to prevent side effects, okay? And when should we check the levels? So if I have the drug that's getting absorbed, it's got a half-life of 18 to 36 hours, when do we normally look at steady state? When you should draw your level? So if you look at kind of like the faster side of that, we usually say wait about, you can wait about 4 to 5 days to check the levels. Okay, usually say about 5 days. So right here where it says 4 to 5 days, most doctors are going to err on the side of 5 days. That way you know if you have somebody that's on the faster side of that metabolism, you're getting a true level. And also always remember to draw a level 12 hours post-dose, okay? Because you want a trough level, you don't want a peak level. That'll be a false level. We have a problem with this at Spring Harbor where we'll have somebody that's on a controlled release and they only get it at bedtime with certain drugs. Like this is going to be true for valproic acid. It's going to be true for lithium. It's going to be true for carbamazepine. You don't want to draw the blood level. For example, if the patient refuses their blood draw at 6 o'clock in the morning, and the other time they come in to draw the blood is 1 o'clock, that's not a trough, okay? But if they're dosing it once a day at bedtime, that's also not a true trough. It's better to do it 1 o'clock. So there's some of those things that can take into consideration depending on where you practice. If it's an outpatient and they're coming in to check, always try and do it at where the trough for the drug would be. Okay? All right, so again, start low, titrate slow. That's going to be key in preventing side effects. You don't have to jack them up to a therapeutic level. You're still going to start out low, titrate up slow. Almost always, you're going to start at 300 milligrams twice a day. You're not going to start out above that, okay? And then titrate up. So again, remember your acute range is what?
0.8 to 1.2.
0.8 to 1.2. If you were to say up to 1.4, I wouldn't say you were wrong. But we normally look at 0.8 to 1.2 because we don't like getting up above 1 in general. We're already going to 1.2, okay? Maintenance phase is
0.4 to
0.4 to 1, right? When we look at steady state, again, 4 to 5 days, draw levels post-dose, and once therapy is achieved, monitor every 2 to 3 months, okay? So it could be a slow titration to really get somebody to that point, and then every 2 to 3 months, you should always have them in and check their levels, check their kidney function. Some other serious side effects. So we already talked about the hand tremor. If it does occur, if it's a fine tremor, to help the patient out with that, we usually treat that with beta blockers. You can use a non-selective beta blocker, or we'll recommend like a low-dose propranolol, so you don't usually get as much of the other side effects you see with some of the more potent beta blockers that are a little more selective. But we usually think, you could use a low dose of atenolol, you could use a low dose propranolol. Those are going to kind of be your more recommended agents just by history what's used. And polyuria and polydipsia. So think about what's going on. It's causing this drug to be excreted through the kidney. It's causing you to want to drink more water. It's causing you to urinate more, right? So you have to make sure that you try and make sure you tell the patient just to maintain adequate fluids, right? About a fifth of your population, 20% of your patients will gain weight on this drug. And you really want to make sure, especially in long-term patients on this drug, watch out for hypothyroidism. It can cause a goiter, causes hypothyroidism in about up to 15% of your patients. And women are 10 times more likely to develop the hypothyroidism. It doesn't mean it doesn't happen in men. You see plenty of men that end up with this on lithium as well. So you're going to follow anybody, but women are more predisposed to developing the hypothyroidism and goiter. It's irreversible when it happens. Okay? If you were to catch it really, really early, maybe you get lucky if you stop the drug. But the vast majority, by the time you catch it, it's a goiter. Okay? It's not from iodine deficiency like we normally think about, like back in the day where people used to get giant goiters. We have enough of that in our diets now with salt. But this is like strictly causes damage to the thyroid over time to cause the hypothyroidism and goiter. Okay? I already talked about leukocytosis, so again, bumping up your white blood cells a little bit. EKG changes. Again, I mentioned to you cardiovascular complications that can happen with these. Neurologic issues, so they can cause dizziness and somnolence in a lot of patients taking it. Okay? Commonly causes dizziness and somnolence, and that's also part of the reason why we titrate low and go up slow. Dermatologic, it can sometimes cause a rash, and it can sometimes also cause some hair loss, especially at the higher doses. It can decrease sex drive. That's not always a horrible thing in a manic patient who's hypersexual. It's also one of the reasons why doctors like this drug in hypersexual patients, because it often will kind of bring them back to even keel. Okay? And metallic taste. So metallic taste, as I talked about, it's a lithium ion. It has a metallic taste if you, especially at like higher levels, even at lower levels, some patients will report this. They may become tolerant to it after taking it for a little while. Some patients, they report it doesn't go away. It's actually sometimes why they'll discontinue the drug if patients say it's intolerable. And urinary incontinence, as you would expect with a lot of polydipsia, sometimes that brings with it too strong of an urge for you to get incontinence. Okay? Questions on any of these? No? You good? Okay. When we look at early versus late, this is kind of where, again, when you start taking the drug versus when you've been taking it forever, you kind of separate these out. GI side effects right away. Muscle weakness and lethargy right away. Sedation, headache, confusion. They might feel like they can't remember things. Decreased concentration. Again, they're usually feeling really good. This medication is going to kind of bring them down to that more euthymic level. They may not necessarily like that, or it might be too much to maintain this in certain patients where they just say, I really can't concentrate on this drug where I was able to well before my manic episode. Okay? That usually does go away. If you keep somebody on it, they usually will become tolerant to it. Tremor, as I talked about, we can modify with beta blockers. It really does sometimes depend on the level, so if they do report tremor, you can try and decrease the dosage a little bit. That can help out. Again, even at low ranges, sometimes you'll see it though. Dry mouth and, as I talked about, leukocytosis, where the white blood cells bump up. So late on is when you can see that hypothyroidism, as I mentioned, and the nephrogenic diabetes insipidus, where you guys have learned about SIADH before, right? Yeah. So that can happen late on. Not as common, luckily, but it does occur. So if I had somebody walk into the emergency department and was throwing up all over the place, had their speech slurred, was walking all over, ataxic, they're going to look like they're drunk, right? Don't confuse them with always having alcohol intoxication. It could be a lithium intoxication. It looks the same when they come in and the levels are through the roof especially. So depending on the plasma level, that's when you start seeing this come in. Okay? Diarrhea and severe nausea and vomiting. They are usually going to be throwing up all over the place in toxicity. Okay? Coarse hand tremor, remember, fine, therapeutic. Coarse, that's not therapeutic, that's too much, that's bad. Okay? So they're going to be shaking. Hyperreflexia, so you go to check the reflexes and their knee could, their foot could pop right up and kick you. I actually had that happen with my first lithium toxicity I went to see. And you see that once where like they, barely touch the knee and it's like, bing! Okay? Hyperreflexia, easy to pop up in toxicity. Drowsiness, lethargy, as you'd expect at lower levels, this gets worse at higher levels. Okay? Lack of coordination, ataxia, so they've got clear gait disturbances, blurred vision, dry mouth. Their urine, if you look at the serum osmolality of the urine, is going to be very dilute. Okay? Confusion, they're going to be having some central nervous system, irritability overall, slurred speech, cardiovascular arrhythmias, and hypotension. The blood pressure can bottom out because of this. Seizures, when it gets too high especially. So this drug, when we talk about all of them, everyone's like, oh, anticonvulsants treat bipolar. Not all anticonvulsants do. The few that do, if you have seizure disorders, can be a good option. Lithium, I'm not going to recommend in a patient who has a seizure disorder. It decreases the seizure threshold. Okay? But in toxicity, regardless of whether you have a seizure disorder or not, it often can cause you to seize. And if the blood levels are above 3.5, you always, always, always dialyze. It is the only psychotropic drug we can dialyze, and you absolutely need to if they're toxic, if you want to save their kidneys. Okay? I definitely would say there are certain doctors that would say less than 3.5. If it's above 2.5 and they're really symptomatic, especially if you don't know if the drug has been fully absorbed, that they may do that earlier. But no matter what, if it is 3.5 or above, you are absolutely dialyzing them. Okay? I should say greater than or equal to 3.5 or greater. Okay? When we look at what you do in a patient that walks through the emergency department and is toxic, you're instantaneously going to lavage them. Get any remaining drug that's in their GI tract out, if at all possible. You're going to make sure you maintain fluids and electrolyte balances. So what's something you should probably put somebody on if they walk through the emergency department in terms of fluids? What would you think? Would you put them on D5W, dextrose, or would you put them on sodium chloride? Makes sense for competitive ions that you would put them on sodium chloride, right? But when you look at what you're going to do for fluid resuscitation, you want to make sure that that's something you kind of pay attention to. Go ahead and put them on sodium chloride. The cardiac and respiratory function, these patients need to be hooked up to a cardiac monitor. High chance of causing arrhythmias, high chance of them bottoming out with hypotension, okay? You don't want to put them into a cardiac arrhythmia that could even turn into like a torsades and cause death, right? Respiratory function should also be monitored because remember it's a central nervous system depressant. High levels can cause decreased respirations as well. Always have them on a seizure precaution, okay? And you always are going to check the lithium levels every 3 to 4 hours. Again, because of the potential absorption issues, you want to make sure whatever you're doing is hopefully bringing them down. Again, only dialyzable drug. Go there if you need to. Don't think twice about it if you're not sure where the levels are going. Okay, in terms of drug interactions, I kind of mentioned these a little bit earlier, but anything that is going to affect your kidney function is going to generally be a contraindication in lithium because it's going to mess with this excretion. Something as simple as starting to take Advil for a headache and you start taking it around the clock to get rid of that headache. Maybe it's because you started lithium and had a headache. It's a common side effect and nobody told you. It interacts. You could make yourself toxic by taking too much of that because NSAIDs decrease renal function. So, your simple drugs everybody takes for pain, headaches, whatever, Aleve, Advil, any of them in that class, even prescriptions, diclofenac, all those, okay? Diuretics, anything that's going to cause increased urination are going to potentially increase your lithium. So your potassium sparing and your thiazides of all of them are known to be a little bit worse. If you think about where they work in the proximal tubule, even though the way that drugs kind of work, and we won't go through a whole pharmacology lecture on that, but the loop diuretics may actually be preferred to some of your potassium sparing and your thiazides if you look at where lithium is working and how those drugs work. You guys will learn more about them in therapeutics too. Just basically know your potassium sparing and your thiazides, okay, are always preferred. In general, I don't like diuretics in somebody who's on lithium, okay, unless you have them really stable and really check those levels to know. Antipsychotics and antidepressants, remember that those can, they can actually increase your central nervous system, depressant effects with antipsychotics, though we often are using them in combination, and antidepressants as well. Your xanthines, these can actually, because of having the increased elimination of lithium, can actually decrease the levels. So caffeine and theophylline, which is sometimes used in like COPD, can actually decrease it. And then cardiovascular drugs. So the rule of thumb is that the easy thing to remember here is that most of the drugs that are going to have anything to do with your kidney function are going to increase your levels. The few times that you're going to have something kind of get collected like caffeine and theophylline, and then sodium chloride, okay? That's why we like to give sodium chloride when somebody gets admitted, right? You want to decrease the levels. Okay? You guys good on those? Questions? All right. So as I talked about, Epstein's anomaly is kind of what put this drug into category D. All right. I will say it is about 1 in 1,000. We have plenty of patients who have bipolar that stay on this drug to stay stabilized throughout pregnancy. So I wouldn't necessarily say rip them off the drug if they get pregnant, or I might say that with some of the other drugs we'll talk about. But this drug, of the three that you normally will think of, lithium, carbamazepine, and valproic acid, is probably the safest, even though it is a category D of the three. It's really that Epstein's anomaly because of that teratogenicity that it's listed as a D. Take it with food or milk. It does help out with the GI side effects. You always want to tell your patients that when they're starting that drug out. And then you want to maintain adequate fluids overall, right? Prevent dehydration. Discontinue the meds and call the doctor. I would say just go to the emergency department immediately if you are considering toxicity. Just go to the emergency department and find out where your level is right away. Okay? And then if it's causing you to have drowsiness, especially be careful. Tell them to make sure they start taking this maybe on a weekend as opposed to weekdays, to pick a day that you don't necessarily have to go in and drive. Okay. Now we get into the next biggie. Not as horrible as lithium, but it's still got a lot of side effects we're going to go through. And you guys are going to see me go through the same slide next year when we hit epilepsy as well. In terms of its indications, if you look at carbamazepine and you look at Depakote, they had approvals for those usages at different times. So if you look at valproic acid, does everybody know what valproic acid versus Depakote and Depakine is from pharmacology? No? Okay. So I'll draw this over there as well. But valproic acid would be like this, okay, like separate molecules. Depakote, we've basically gone and put them together, and they're enteric-coated to help out with the GI tract as well. So when the drug by itself, again, pretty hard on the GI tract. The fact that these are together, and then they separate to this in the GI tract, okay, that makes it a little bit easier on the stomach. Okay, so this is your valproic acid, okay, this is your Depakote. So when you take it orally in the GI tract, it converts to valproic acid. So Depakote, you're going to hear me talk about these, like Depakote, Depakine, valproic acid. They all end up the same thing in your body. You would do a valproic acid level or divalproic sodium level. It's all the same thing, okay? So again, Depakote, molecules are bound together in the GI tract, and it turns into valproic acid. So it is why you'll see valproic acid is actually old drug. It's a lot cheaper than Depakote. Depakote has, again, the enteric coating, has it instead of in the stomach, in the duodenal tract, the drug breaks down, less GI symptoms, okay? So you have about a 65 to 70% response in mania with this drug. This drug does have a lot less toxicity that's associated with lithium, but still you have to maintain levels with this one. Much more broad therapeutic window with this, but you still have to worry about some side effects, more so for drug interactions because of the protein binding. Okay, you want to remember this drug is highly protein bound. So other drugs like warfarin that you see a lot of patients end up on for a blood thinner, some of your anti-epileptics, phenytoin. Even though phenytoin might induce the drug because of the protein binding, it can increase the drug. It gets really variable and messy. Okay, so make sure you really watch out for that. When we look at predictors of response, this drug actually works pretty good in our rapid cyclers. So if I have somebody that I'm concerned about as a rapid cycler, I'm probably going to look at carbamazepine and Depakote more than I am lithium. Okay? It also works pretty well for your mixed bipolar we talked about, so where they might have periods of being elevated mood and depressed mood all within 1 week. It does have, for mood lability, this drug is pretty good. Okay? I think I mentioned to you guys that aggressive male patients, this is kind of a preferred drug for really treating irritability and aggression behaviors. It's kind of, in our bipolar patients that have a history of violence, this tends to be one of those drugs that will lean towards a little faster. It's good for that population. It has a lot of other indications you'll see for this. As I mentioned, epilepsy, but migraine headaches, it's also used for that. Neurological findings. If you know that somebody has a traumatic brain injury, that this drug overall not only will help for seizures, but some of that mood lability as well. They kind of like that drug is preferred for traumatic brain injury patients. And organic mania, so meaning that there is some sort of physiological abnormality in the brain that's probably inducing the manic symptoms. This drug kind of calms things down as a whole. When we talk about it in epilepsy, you're going to hear me talk about it as broad spectrum. You can almost think about that for mood disorders as well. It's got a broad spectrum approach for kind of just as an overall stabilizing, decreasing overall manic effects. If somebody has failed lithium, Depakote will often work in those patients. So again, we don't always know if we're picking the exact right drug when we start out, but we know that lithium failures, it does work pretty good overall. Comorbid substance abuse is another favorite because this drug doesn't have as much of a issue. If you've got somebody who, for example, is on lithium and drinking, you can imagine with some of the toxicity issues with that, how problematic that could be. Though this drug has a therapeutic window that we need to be concerned about, it's not as labile, like because of the excretion of the urine and the kidney effects and all that, it's not as much of a concern. So it is a little bit preferred in substance abuse disorders for that reason, among others. Comorbid psychiatric illnesses. So again, I talked about it's used for a lot of different purposes. It sometimes is even used specifically for panic disorders and anxiety disorders, kind of a little more off-label because of the side effects. But if you have somebody who has anxiety going along with the bipolar symptoms and it's a major effect for them, a major issue, they sometimes will go right to Depakote as well. Okay? Irritability, aggression, impulsive behavior, I talked about that already. They sometimes, again, even if it's somebody who doesn't have bipolar disorder, will use it for that purpose. Okay? All right. When we look at dosages for this drug overall, we are really looking at ranges, again, is what we're keying into. But this drug, when we're looking at it, usually you're going to start out at about 500, titrate up to about 3,000. You're usually going to go, again, because the GI side effects, break it out into twice a day. The maximum that you're ever going to give is 60 milligrams per kilogram per day. Always give it with food, same as lithium, to minimize GI issues. And the interesting thing here is we use this a lot if we're trying to get somebody bumped up to a therapeutic level. If they're manic and they come in and you want to start them and get them therapeutic right away, take their weight and add a 0. So if they're 150 pounds, you want to try and get them on, start them right away. You can start them right off at 1500. Now you might have to worry about obviously side effects with that, but if you give, say, Depakote extended release that you can give once a day, that usually works pretty well for that. So you can start right out at that for a fast crisis stabilization dosage. I will also tell you that that same rule applies for where you often have to go to see a therapeutic effect. Okay? So when we're talking about blood levels between 50 to 100, up to 125, and in some cases up to 150. Okay? If you look at seizures, they list 50 to 100. We still look at about that same range for bipolar. Doctors will, like, if you look at what's approved for acute bipolar treatment, it does say up to 125, and if they're having issues and not having major side effects, again, this is where that 150 can be used if needed. I want you guys generally, if you're thinking at the average range for most patients, it is generally still going to be 50 to 100, and I say that for the same reason I told you 1 with lithium. You can remember 100 with valproic acid. Above 100, if you're going to start seeing side effects, is usually when that's going to occur. Okay? So know that our therapeutic range, same with lithium, 125, potentially up to 150. You're talking, you may potentially see side effects with that. You probably will to some extent. Okay? When we're looking at monitoring as a whole, same thing. You always want to start out with your baseline. This drug has been known to cause thrombocytopenia, so you have to monitor your platelets. It's good to get a baseline for that. Okay? It also can be hepatotoxic. So you want to start out and make sure that their liver enzymes are okay to begin the drug. Always want to do your thyroid panel. This drug is not like lithium where it causes hypothyroidism. But the problem is that we look at this as a baseline for all of our bipolar patients, so I still put thyroid in there. I want you guys to think thyroid. When you're looking mania, rule out hypo or hypothyroidism as an issue. Because remember, even in our patients that are manic, if they are hyperthyroid, it makes sense. If they are hypothyroid, they have found that hypothyroid patients with hypothyroidism, are at an increased risk for having increased cycles, even if they're manic. So hypothyroidism, though it normally causes depression, even in our manic patients can be of concern. Okay? All right, our electrolytes. This drug can also cause, not as commonly, there's some reports of it causing hyponatremia. It's not as bad as the one I want you to remember for hyponatremia, which is more so your carbamazepine and its cousin oxcarbazepine. And I'll talk about that more. But you really are looking at, with this drug, though all of these are listed, I want you guys to, if you're going to highlight any of these, you want to do your CBC and your LFTs. Okay? Those are the two that you're going to have to worry about for side effects more than the others, and they have to be, it has to pretty much be normal for platelets, and it has to be normal for liver function before I'd start this. You also need to know that when you start this drug, you can see the liver enzymes transiently increase. So that's why it's good to know where your baseline is. Okay? All right, when we're looking at overall side effects, neurologically, again, it's a pretty good central nervous system depressant overall. You can notice some gait abnormalities, ataxia, dizziness, drowsiness. You can also see tremor. It's not the same type of tremor you'll see in lithium, where that's a little bit more predictable. It's not as common, but you still can see the patient kind of basically just a little shaky with this drug, okay? When we look GI, again, don't underestimate the GI symptoms with this. Even if you give Depakote ER, some patients will still complain about GI side effects. Taking it with food is really, really helpful to minimize those. And again, hematologically, that thrombocytopenia can rule out using the drug. You also can see, and some of this has to do with some of the protein binding and some of those that coagulation cascades and all that you guys will learn in therapeutics too, but it can prolong bleeding times. Now, some of that could be relation to, this has been found higher in patients that have liver issues with this drug, because the liver itself can if that's impaired, cause prolonged bleeding times. But remember that it is something to think about, that you always want to get an idea if they notice signs of bruising or bleeding, that you would want to take a look at their INR, okay? All right, and I'm gonna have you guys take a look at this last slide. The big thing that I can't stress enough before we get out today, you know how I mentioned kidney failure, okay, is something you always think about with lithium? I want you guys to remember teratogenicity with valproic acid. This is category D, it should be X, okay? This has clearly been found in females who have taken this drug, not only to cause teratogenicity of the fetus when they're born for increasing the risk for spina bifida, it causes neural tube defects because it blocks the folate early on in pregnancy, and so it causes neural tube defects, especially in that first trimester when a lot of women don't know they're pregnant. And it also causes lower IQs in babies that have been exposed any semester, or any trimester, okay? Any trimester. So when you're thinking about this drug, remember category D, please. The other problem is that it causes polycystic ovarian syndrome, PCOS. So in females of childbearing age that take this drug, we can actually make it harder for them if they ever do want to conceive to get pregnant. That can be a permanent disorder that develops where they develop cysts on the ovaries, polycystic ovarian syndrome, okay? So do not forget that issue with this drug. They did a study actually showing that 42% of women that were in this study developed polycystic ovarian syndrome on Depakote. That's ridiculous, okay? You don't want to use this drug in a female unless you have to. Yes?
I have a quick question. Is it category D or X?
It is category D. I'm saying it should be X. Normally stuff with these types of side effects that have been found in fetuses and infants, when they're exposed, it'll give it an X. It is category D though. I mentioned the hepatologic and the dermatologic. You also can have some hair changes, alopecia, hair loss, and usually this fine maculopapular rash can develop. It's not usually too bad. Sometimes it can be a transient thing and go away. You would just monitor that. But the hepatologic, don't forget this drug has been known to cause liver failure as well. Okay, so monitor those LFTs. All right, and then I'm gonna leave you guys with the drug interaction slides. The one I'm gonna tell you to watch out. We already talked about halate protein bound drugs, CNS depressants. Lithium can actually increase valproic acid, and it is a enzyme inhibitor of metabolism. So the major interaction is with lamictal, and we'll talk about lamictal tomorrow. This is a huge interaction because lamictal, we'll talk about, can cause Stevens-Johnson syndrome. If you don't know what that is, you'll see some ugly pictures of it tomorrow, but it's pretty horrible. It causes the mucosal linings of your body to slough off, including your eyes, your GI tract, you name it. So pretty horrible. So you want to highlight one serious drug interaction you never want to forget, and I will burn this in your brains tomorrow, I promise. You will never forget lamictal causes this issue, and valproic acid, major drug interaction with that to increase your risk for it. Okay? Questions before we get out? You guys good? Okay, don't feel, if you guys want to, I have a couple extra cards up here for Muddy Points. Come and take them and we can go over them tomorrow. Or put the stuff on the discussion board.